Converting clinical facts into NBME-style next best step decisions takes a very specific cognitive framework. We're not just memorizing diseases here, we are learning exactly how to navigate the exam mode decision tree. You've got to weigh clues, dodge false anchors, and treat clinical thresholds as absolute action switches to lock in the correct answer.
We have a tight focus today, covering 5 high-yield logic rules. We'll hit clue weighting and false anchors, clinical probability, threshold memory, pattern interrupts, and finally, distractor calibration and the final answer audit.
Let's jump into Section 1, Clue Weighting and False Anchors. Not every clinical clue carries equal weight. Question stems are literally designed to bait premature closure. They feed you a classic presentation to anchor you, and then they drop an interrupting clue. Take chest pain. The false anchor baits you into assuming acute coronary syndrome. Sure, exertional pain relieved by rest points to CAD, but the interrupting clue, say, pain lasting over an hour that's not exertional and provoked by lying down, that heavily outweighs the general symptom. It immediately shifts your differential to an esophageal cause, like GERD.
Let's look at infectious disease. A patient comes in with a runny nose, a mild sore throat, and a cough. It is super easy to anchor to a standard viral upper respiratory syndrome, right? But the interrupting clue here is the onset. A slow, stepwise onset confirms that common cold, but an abrupt, dramatic onset, that immediately flips the base rate to influenza, especially if you see a high fever and myalgias. The speed of onset is the management-changing clue.
Moving to Section 2, Clinical Probability and Risk.
Exam mode integration means you need to build sequential probability trees. You have to separate branches of a diagnostic pathway instead of just mashing all the tests together. Take the modified Wells criteria for pulmonary embolism. This dictates your exact pathway before you order a single imaging study. If the score is 4 or less, PE is unlikely, so you branch off to a D-dimer. But if that score is greater than 4, PE is likely, which branches you directly to immediate anticoagulation, followed by CT angiography. The score itself is the fork in the road.
Now, look out for override clues that alter that pathway. Let's say your probability tree points to CT angiography, but the patient has severe renal disease or happens to be pregnant. Those are overrides. Because they can't tolerate IV contrast, or you need to avoid fetal radiation, the correct next best step calibrates right away from the CTA and shifts directly to a V/Q scan.
Section 3, Threshold Memory for Action.
Stop treating clinical thresholds as passive trivia. On test day, thresholds are hard action switches. For an abdominal aortic aneurysm, that 5.5 centimeter mark is the exact action switch. If an asymptomatic AAA is below 5.5 centimeters, your switch is set to routine ultrasound surveillance. But the exact second it hits or crosses that 5.5 mark, the switch completely flips to elective repair.
We see this exact strict logic in DKA management. You start IV fluids and insulin, sure, but your very next steps are entirely dictated by specific lab thresholds. When serum glucose drops below 200, you hit a switch. You must add dextrose to the fluids and dial back the insulin. Potassium below 5.3, another switch. You add potassium replacement. Blood pH hits 6.9 or lower, you consider bicarbonate. These numbers strictly dictate your very next order.
In ischemic stroke, blood pressure thresholds act as permissive or prohibitive action switches. If you're planning to give thrombolytics, your strict threshold is 185/110. You have to lower the pressure below that before giving TPA. But if thrombolytics aren't indicated, the switch flips to permissive hypertension, meaning you do absolutely nothing until the blood pressure crosses the extreme threshold of 220/120.
Section 4, Pattern Interrupts Instability.
You've got to identify the destabilizing factors that force a radical change in the standard pathway. Before you even think about selecting a therapeutic intervention, you have to deploy the ultimate pattern interrupt. Is the patient hemodynamically stable? This single question overrides almost everything else in the stem. Look at how this plays out with a ruptured ovarian cyst. A young woman comes in with sudden lower abdominal pain. If her vitals show she's hemodynamically stable, the correct answer is just supportive care, like analgesics. But if her pressure is tanking and she's unstable, that instability instantly calibrates the right answer away from observation and sends her straight to urgent surgery. Contraindications are another huge pattern interrupt. A patient arrives within 3 hours of classic ischemic stroke symptoms. The stem is screaming TPA. But wait, the pattern interrupt is buried right there in the history. Maybe an MI in the past 3 months, a GI or GU bleed in the last 21 days, a seizure right at symptom onset, or pregnancy. Any single one of these absolute contraindications makes TPA the wrong distractor and forces you to a different path, like giving aspirin. Applying pattern interrupts to OB, imagine you're looking at a fetal heart tracing. If you see variable decelerations, your primary action is just maternal repositioning, left lateral decubitus. But if the pattern interrupts with late decelerations, where the onset is after the peak of the contraction, management instantly shifts to intrauterine resuscitation, oxygen, and potentially a C-section if that fails. Consider a pregnant patient with sudden onset vaginal bleeding and abdominal pain. Your differential is split between abruptio placenta and uterine rupture. The pattern interrupt that definitively overrides your other clues is the contraction pattern. Regular, high-frequency, low-intensity contractions point directly to abruptio placenta. Irregular, decreasing contractions would point you to a uterine rupture. Finally, Section 5, Distractor Calibration and the Final Audit. To master the NBME, you have to recognize the exact moment a common, safe distractor actually becomes the correct answer choice. A patient has abdominal pain linked to defecation and altered stool frequency for months. The classic distractor is reassurance and symptom management. That's totally right for standard IBS, but it becomes wrong the second you spot an alarm feature. If they're over 50, have rectal bleeding, unexplained weight loss, or an elevated CRP, those features calibrate the answer completely away from symptom management, making a colonoscopy the only right choice. Let's say a patient develops a cardioembolic stroke secondary to bacterial endocarditis. The standard stroke algorithm might make you think anticoagulation, but that's wrong here. The right move is IV antibiotics and observation. But the exact moment that conservative approach becomes wrong is if the patient develops congestive heart failure. That single complication recalibrates the answer, making surgical valve replacement the correct next step. Which brings us to the final rule. Before you lock in any selection, force yourself to complete this final answer audit sentence. The management changing clue is blank, so the next step is blank rather than blank. Don't guess. Find the specific clue that interrupts the pattern, crosses a threshold, or alters the probability. Weigh your clues against false anchors. Use sequential probability trees. Treat thresholds as absolute action switches. Respect patient stability as the ultimate pattern interrupt, and know exactly when a safe distractor becomes the mandatory intervention.